Thank you for joining today's session. My name is Alina Schwarz. I'm the Executive Manager of the World Stroke Academy and webinar organizer for the World Stroke Organization. Today we have a webinar which will be a two-part series focusing on post-stroke spasticity, and we're honored to have three fantastic speakers with us: Professor Lydia Abdul Latif, Associate Professor Steven Faux, and Dr. Vaikunthan Rajaratnam. Joining us also is Professor Julie Bernhardt, who will moderate the Q&A session at the end of this webinar. Before we get started, a little housekeeping. Please post all your questions in the Q&A box at the bottom of the Zoom panel, and we'll discuss them and bring them up during the Q&A session. If you post about the event on Twitter, don't forget to tag us at worldstroke.org, at worldstroke@, or use the hashtag WSO webinars. And we've also prepared a short feedback form, which you'll be directed automatically at the end of this webinar. So it will be great if you could take a few minutes to fill this form in and let us know what your opinion was on the webinar and how you liked it. So without much further ado, I'd now like to introduce our first presenter, Professor Dr. Lydia Abdul Latif, who will talk about the topic spasticity and rehabilitation. Professor Dr. Lydia Abdul Latif is the consultant rehabilitation physician and chief medical officer of Regan Rehabilitation Hospital. Her academic days were at the University of Malaya, where she still serves as visiting consultant. Her specialty is in neurorehabilitation, with a key interest in brain neuroplasticity and recovery in stroke. And she was a research fellow at the Spalding Rehab Hospital, teaching hospital for Harvard Medical School, where she trained in the field of neuromodulation. Her scholarly contributions include publication in neuromodulation, stroke, and rehabilitation. Over to you, Lydia.
Thank you, Alina. Assalamualaikum, and a very good afternoon and very good evening to some other parts of the world. I'm Dr. Lydia from Malaysia, and it is indeed an honor for me to be part of this post-stroke spasticity webinar with such eminent moderator, Professor Julie Bernhardt, and together with Professor Faux from Australia and Dr. Rajaratnam. And I will be speaking on, let me just share my screen. Okay, so my topic today will be on spasticity and rehabilitation. Okay. All right, so, okay. So first, I have nothing to disclose. All right, so spasticity. Spasticity is a major disabling symptoms after cerebral or a spinal lesion. And spasticity is a complication of stroke, and we term it as post-stroke spasticity. It is also part of upper motor neuron syndrome. And if you look at the definition of spasticity, it is a motor disorder characterized by velocity-dependent increase in tonic stretch reflex. And the key word here is velocity-dependent. The reported incidence of post-stroke spasticity ranges from 17 to 43%, so it is quite common. And for us in rehabilitation, because spasticity may not be observed during the early phase of stroke, hence early recognition of spasticity and identification of the predictors can assist the rehab team in mitigating this problem. So different predictors have been suggested in different studies, and some of these include development of increasing muscle tone, sensory impairment, hemorrhagic stroke is more common to get spasticity, especially in younger patients, severe paresis, lower Bartel index, and all this has been suggested to have higher risk of developing post-stroke spasticity. So we know that the complication is various. Complication following spasticity, they can give rise to abnormal posture, and there are specific common pattern for upper limb and lower limb, as in the diagram below for stroke. It causes a lot of pain and discomfort for the patient. It interferes with activities of daily living. It interferes with nursing care. It affects walking, what is known as spastic movement disorders, and overall, it reduces one's quality of life. As for assessment of spasticity, in order to quantify the full impact of post-stroke spasticity, we need our assessment should include measures of passive stretch, volitional movement, active and passive function, merely to differentiate the various components of upper motor neuron syndrome, that is spasticity, spasticity co-contraction, identifying spastic dystonia, or is it just a synergistic limb pattern, contractures, and weakness. So just quickly, assessment of spasticity, we can do direct or indirect measures. The most common one being a modified Ashworth scale. We use this quite commonly. Tardieu scale, if we are looking at dynamic spasticity. We can also be a bit more objective by looking at by using electromyography, using the neuroexcitability index such as the Hmax-Mmax ratio. And the other measurement that is very relevant when we are assessing spasticity would include active and passive range of motion using simple goniometry, assessing the pain using a visual analog pain score, muscle strength, looking at the balance using Berg balance scale, and of course the skin integrity would be equally important. So rehabilitation, we know, is very goal-directed, and hence the treatment management for post-stroke spasticity can be, you can look at in several categories. For example, the first one is to potentiate the medication, whereby we can use neuromuscular electrical stimulation after botulinum toxin injection to restore the biomechanics of the joint using orthosis, stretching using serial casting, to improve the motor control using neurofacilitatory technique and functional electrical stimulation, strengthening the weak muscle, of course, using resistant training program, hydrotherapy, and physical agent. So we know the impact of spasticity and muscle lengthening. It can cause contractures because spastic muscle can be shortened, and also the antagonist muscle are usually pretty weak. All right. So in rehabilitation, muscle stretching is one of the most commonly used in clinical practice. And the aim is to improve the viscoelastic properties of the muscle tendon unit and also to influence the neuroexcitability. There are various ways that we can actually do muscle stretching. These include active stretching, passive stretching, prolonged positioning, isotonic stretching, whereby the limb is moved slowly to its maximum range of motion and is held in that position. Or we can also do isokinetic stretching, where the limb is moved continuously with force at a constant velocity. Thus, the stretch position is not maintained. So this is just to show the effect of muscle stretching on the viscoelastic properties in the MTU, that is the muscle tendon unit. Okay. So standing is also a very common practice that we use, either standing using a tilt table or a standing frame. And of course, standing is used to promote the anti-gravity muscle in the trunk and in lower limb. It is also to maintain and improve soft tissue and joint flexibility. Standing also helps to modulate the neural component of spasticity through prolonged stretch. It can alter the sensory input, reduce the lower limb spasm, and overall do provide positive psychological effect for the patient. As I mentioned, the use of spleen and orthosis, there's not much level 1 evidence, but what is there out there in the literature, by using spleen, it does influence the muscle extensibility, hence it does help to reduce and prevent contractures. And if we use a static and dynamic passive movement stretch, To some extent, it does help to decrease motor neuron excitability. It also increases the flexibility of the joint, and it does help to reduce tensile stretch on the soft tissue. So this is the common antispastic splint that we use for the upper limb. The wrist is kept a little bit in a dorsiflexion, and this is what we usually would prescribe for wrist flexion spasticity. So this is quite a recent systematic review that looks at static stretching positioning for post-stroke spasticity compared to no therapy at all. Even though what they find there is low quality evidence, but the result did suggest that static stretching positioning helped to reduce wrist flexion spasticity compared to no therapy at all. So, rehabilitation treatment goal for post-stroke spasticity, like I mentioned, the rehabilitation is very goal-driven. We can broadly classify into two. The first one for low-level patient who have passive function, and the second one is for a much higher level patient with active function. So, for patient with low level, the goal may include improving the positioning of the patient for orthotic fitting and to remain compliance of orthotic fitting, to help them to reduce spasm, reduce pain, assist with nursing care, and of course to prevent complication. The goal for high-level patient, for the active function, is of course geared towards improving their activities of daily living. For upper limb, it is to improve the prehensile, the grabs and the release, to improve upper limb function in terms of reaching and overhead activities. For walking, to improve mobility, to improve the speed, balance and quality of a gait, and of course to reduce pain. So this is serial casting. This is a paper that describes the technique of serial casting that is done in a sitting position, which is quite interesting. And you can see the various type of casting from the very extreme through the several weeks until they get the neutral position for the ankle, right? So this is what we normally would go through as well. Okay, so this is just a short video of a patient of mine who had suffered a stroke, right? So we can see that he has got spasticity over his right lower limb. You can see that the foot is inverted and there's weak dorsiflexion, right? And this is in the different angle. So you can see that his gait is much slower and
is it causing you pain?
So he does complain of pain. Okay, so this is him after 3 months of rehabilitation. So the only thing that I did not do is to inject him with a botulinum toxin. So what we did was a lot of muscle stretching, strengthening, prescribed him with ankle foot orthosis. So just look at his video. So you can see that the right foot, it's more subtle. The inversion is much lesser, but there's still a lot of weakness, right? Okay, so this is, sorry, this is from a different angle. So his gait is much faster, but you can see that the deformity is much lesser in terms of the inversion. But we still need to work on strengthening of the antagonist muscle, which is the dorsiflexus. All right, the other physical modalities, again, the literature is not astounding out there, but there are alternatives that can be used for spasticity, though the mechanism, the actual mechanism for reduction of spasticity is not known. So the first one is ultrasound. The second one is using ESWT, or what's known as extracorporeal shockwave therapy. And the third one is cryotherapy, right? Cryotherapy has been shown to diminish the resistance of spastic muscle to rapid stretching, and it does help to decrease and abolish clonus. And some studies using ultrasound do show some reduction in terms of electromyographic findings of the H reflex parameters, which suggests the promising use of it in reducing spasticity. So this is a recent paper that compare the use of therapeutic ultrasound and radial ESWT. And this study, the finding shows that there is reduction in spasticity, but there is no difference between these two modalities. So our colleagues in Barcelona is embarking in studying a lot more in shockwave therapy. So we look forward to their findings later on. There are also emerging techniques in rehabilitation. I myself has been involved in using RTMS, but it's a very pilot study where we use a repetitive transcranial magnetic stimulation, and it does show some promising result in helping to reduce spasticity in post-stroke patient, right? Okay, so the take-home message: spasticity result in undesirable disabling complication. There are growing or increasing understanding in the area of rehabilitation or non-pharmacological treatment for spasticity. And rehabilitation has various approaches, hence one's need to see the clinical condition of the patient before deciding which approach is suitable. And treatment approach for spastic patient still need a combination of pharmacological as well as non-pharmacological. So future direction, I think further research in this field is much recommended. So I would like to definitely be part of the stroke recovery roundtable research group that Prof Bernhardt is involved. And the other thing that I would recommend is to the existing evidence do support the potential role of rehabilitation intervention as a therapeutic tool. And there are a few emerging techniques that needs to be explored. But nevertheless, because there are a lot of approaches, hence guidelines need to be in place for us to be able to use it usefully in our patient. So with that, I would like to thank you for your kind attention for my session. Thank you.
Thank you very much, Lydia. That was an excellent talk, and I'm looking forward to the discussion at the end of the session. We'll move on to our next speaker. The topic of our next talk is botulinum toxin in post-stroke spasticity. And for this, we welcome Associate Professor Steven Faux. Steven Faux is the Director of the Departments of Rehabilitation and Pain Medicine at St. Vincent's Hospital in Sydney, and the conjoint Associate Professor of Medicine at the University of New South Wales, and Adjunct Associate Professor of Medicine at the University of Notre Dame. His research interests are in management of spasticity, trauma management, and stroke rehabilitation. And he has conducted several trials in device development for rehabilitation and conducted the first Australian RCT in telerehabilitation for chronic pain and the use of an online multidisciplinary resource for chronic pain. And he's conducted research in brain injury in Canada as a visiting professor at McGill University and maintains active research collaborations in France, the UK, and India. So over to you, Professor Faux. Oh.
Yep, thank you very much. I'm sorry, I'm just getting used to the platform. So I'm really thankful from the World Stroke Organisation, my colleague, Julie Bernhardt, to allow me to present some work I was involved with. I'm just going to share my screen. Oh, I hope that worked. Just try to open that up. Okay, just having a little bit of trouble opening that up, but I'll try and open myself up. There we go. I just wanted to to firstly acknowledge Natasha Lannon, who is the person who actually ran this trial. I was part of the team, and I'm just having a little bit of trouble opening this up. Let me just see. Right. There we go. Here we go. And
Reopen it. Yeah.
And I'm sharing my screen now. When I do that, I sort of get smaller, but I'll try and work out how to do that. So I just want to acknowledge the other collaborators in this study. And this study is a study of the use of botulinum toxin with therapy. So we know that botulinum toxin has been used to manage spasticity, but the question as to when to use it and also how to use therapy following the use of the botulinum toxin has been always a question. We have built most of our practices on the theory that rehabilitation should be offered at the same time as botulinum toxin is being given. And that certainly is one of the guidelines. So our research question was, in stroke survivors who are attending a spasticity clinic and who are scheduled to receive botulinum toxin, is adding 3 months of evidence-based movement training more effective than providing a simple handout for exercises in terms of goal attainment and upper limb activity? So in this study, we had 7 different spasticity clinics, and patients were randomized to either receive the botulinum toxin and a handout and be sent away to be followed up in 3 months' time, or they were going to get the botulinum toxin. They were going to get 2 to 3 weeks of serial casting, because that was there's level 1 evidence to show that is of benefit in improving contracture. And then they were going to receive intensive evidence-based therapy for the upper limb undertaken by therapists 2 to 3 times a week. It was a 12-week program. 2 weeks of it was focused on the serial casting, and 10 weeks of we used electrical stimulation, progressive resistance exercises, and task-specific motor training. And this is all done with trained occupational therapists who are trained in the protocol of the program. The control group, however, were given a simple list of exercises that involve stretching, passive stretching with your hands, progressive resistant exercise movement, and part practice or encouragement of using their hand. And they were simply reviewed at 3 months. We screened about 1,253 patients. We screened 200 patients of the 1,200 who were attending our clinics. Many of them were non-stroke patients. Then we excluded some who were ineligible to attend and some refused, which left us with about 140 patients who were then randomized. 69 in the experimental group getting the home and clinic-based treatments, and 71 in the control group getting just written instructions. And then we reviewed their outcome measures at 3 months. Now, this is the sort of average age of the experimental group and the ones in the control group. The sex distribution was fairly much equal, slightly more women in the experimental group. But this is what I think is quite important to look at. The time from the stroke was 3.5 years. And this is quite significant because it was decided that we didn't want to accept people into the trial who were having active and ongoing rehabilitation. So the people who were selected were people for whom the intense rehabilitation period was sort of over. There was an equal number of those with impaired sensation. And as you can see, their upper limb activity, or the box and blocks test, was quite poor in both groups. So what you're seeing is a group of people with spasticity but poor upper limb function, and the Taji scale indicates reasonably significant spasticity. And here's their outcomes, which I think is quite interesting. There was no difference between the experimental and the control group in the goal attainment scale. That's a scale where the patient sort of indicates what goals they would like to achieve, and they're given a score. If they are able to achieve them, they score greater than 1. In the upper limb box and blocks test, they did both improve equally. So the question was whether the very active and intense occupational therapy following the therapy was of any benefit or not. And clearly in this randomized controlled study, it appeared that this intense rehabilitation approach following the botulinum toxin was equal to giving the patient a handout and asking them to do everything themselves. There was very little difference within the groups, and there was difference between the groups were also not really significant. So one of the things we were concerned about was that when we put the groups together and looked at their improvements, some of them improved in their GAS scores, but very few improved in their upper limb activity. So the question was then raised, in this group of very chronic strokes, is giving botulinum toxin and either form of post-injection therapy of any benefit at all? And I think this is an extremely important question to discuss. The implications are that what we found was that people in the very intense group who had the intense therapy had very good adherence to their programs, but they had very little improvement. We did notice that all the patients in this study, all the participants, had very weak upper limb function at baseline. So we're looking at a very chronic group that is maybe, it could be argued, unlikely to improve anyway. And the participants were quite far past their incident stroke timing. For further information, you should contact Professor Natasha Lannon, who, together with all these organisations, the Alfred Health, the La Trobe University, the University of Sydney, Monash and Newcastle and Flinders universities, contributed to the study, as did mine from the University of New South Wales. Now, I'm going to have trouble trying to get back on, but I'm going to thank you very much for listening to me, and I'm going to undo my video and look forward to the next speaker. So thank you very much.
Thank you very much, Stephen. Excellent talk. A warm welcome now to our next guest speaker, Dr. Vaikunthan Rajaratnam, who will talk about integrated care pathway and the role of surgery for stroke spasticity. Dr. Vaikunthan Rajaratnam graduated from the University of Malaya and is an accredited hand surgeon, medical educator, and instructional designer, and has practiced and taught over the last 3 decades in Malaysia, the NHS, and the UK and Singapore. He regularly conducts teaching and training programs in Bangladesh, Sri Lanka, and Cambodia. He has developed and maintains open online educational programs for hand surgery and medical education. We are very pleased to have you with us today, so over to you.
Good afternoon, everybody. Thank you very much for this invitation. Okay. So I'm just going to talk about our experience in Singapore and the establishment of an integrated pathway for stroke spasticity. So I have no potential conflicts. What we're going to cover today is an evidence-based approach to the design and development of a pathway. We use the narrative synthesis of post-stroke spasticity, and we redefine post-stroke spasticity care in a comprehensive and integrated fashion. And we developed criteria for surgical intervention, and we did a preliminary evaluation of our outcomes and our early experience with the use of this new pathway. And we'll talk a little bit about what's the further areas of development. As I declare my non-interest, I would urge you and the attendees, for the next 10 minutes, just put aside your views and opinions about what you have practiced in post-stroke spasticity. I think this is a tremendously under investigated area, and we have failed to look at the psychosocial impact of spasticity. So I'm going to share with you some of the thoughts and ideas which don't come from mainstream stroke literature, but in other areas of cognitive neuroscience, psychology, and engineering. So we are all familiar with the problems of strokes in terms of the spasticity in post-stroke. So we exclude those without spasticity. There's been a lot of emphasis on the biophysical aspects of spasticity and very little on the psychosocial aspects of spasticity. So we'll look at that, and we'll touch a bit on that. So we used the DDR model, which is a design and developmental research model, for identifying a problem and then getting the experts and getting the evidence for it, designing solutions and building a prototype, and then trying that out, evaluate, redesign, and pilot. So we've currently rolled out our integrated pathway in Singapore. So traditionally, we found that the patient post-stroke spasticity usually were harbored around the neurologist who managed them and the stroke physician, followed by mainly the rehab physician and therapist. And the surgeon gets involved very rarely. And in the 3 decades that I've been practicing as a hand surgeon, we usually end up seeing the patients who's got the contractures, even later than that, with the fingers digging into the palm. And I had a patient in the NHS who had dug so much into the hand that the thumb had fused with the index finger, and we had to amputate the finger. So that's kind of late, and that's not satisfactory. So we were looking forward to see a much more multidisciplinary team approach with the patient in the center. So we're looking at stroke physician and neurologists, rehab physicians, specialty nurses, therapists, and the surgeon being involved as part of the team even early to provide some form of care to the patient, and also to start the conversation going and building the team approach with the patient and the role of surgery to help with the patient's functions. So what we did was as part of the team, I left the names there because we've got 10 minutes. There's a big team. We had neurologists on our team. We had rehab physicians. We had occupational therapists, physiotherapists, hand surgeons. We had a resident. We had a couple of medical students help us out in designing this pathway. So we looked at the evidence, we looked at some literature review and the role of neurectomy. So neurectomy's role is to reduce spasticity. Spasticity arises from the loss of inhibition of the upper motor neuron and the lower motor neuron. So most of the hand surgeons are very familiar with lower motor neuron lesion, and that's where the understanding of, and the concept of spasticity is sometimes lost. So this was this review. It works. There is a recurrence rate. You got to cut the branches to the nerve, not the main nerve. We'll look at some of the other evidence for this. So this was a systematic review by Wheelam and group. And this is the terms that we use. So what's happening is when you inject Botox into the muscles, you're trying to paralyze the motor end plate. Whereas what we do in neurectomy is to take the branches of it. And in principle, you want to take out about 75 to 80% of the axons that goes into that particular muscle that is providing the problem. You must understand that there's an interconnectedness of the neurons within the spinal cord and in the brain. So increase in spasticity and increase in the gamma reflex that returns back also dissipates to the other motor neurons, producing problems in other segments of the motor unit. So one of the landmark papers that came out from Shanghai, China, was in 2018, the use of a contralateral C7 nerve root from the brachial plexus to the C7 of the affected limb. We use this in brachial plexus reanimation for paralyzed upper limb, and we have commonly used it. I've used it from the opposite C7 and put it into the C7 or the median nerve of the affected limb. So we've seen these connections happening in the brain, and this was done in a level 1 study, RCT, and they had shown that there was an increase in function as compared to just rehabilitation alone. There's a reduction in spasticity, and there were proof of physical connection, physiological connection between the ipsilateral cerebral hemisphere and the paralyzed hand. However, here's where people who are blinkered. On the same journal, the same volume, obviously they had insight. This group of authors who are basically lower motor neuron surgeons. Yes, so here was on the same journal, a rebuttal or a commentary by chosen authors who are basically peripheral nerve surgeons whom I know, and they were lower motor neurons. So they contradicted some of the, they're saying they were difficult to explain the results of the Shanghai study. And I put them there, I won't go into details. By cutting the C7 on the affected limb, you do a very proximal neurectomy and you reduce the spasticity in the whole limb. And they said that probably was the main cause of the outcomes that being better. But when there were connections occurring in the ipsilateral cortex, indicating that there were connections between the C7. So because of not understanding what's happening in the cognitive neuroscience area, research is happening, which most surgeons don't read. So that's where the failure to understand what happens. I think it's a very exciting work from Shanghai. There have been people who have gone from the US to validate the results of the Shanghai group. So we await for further studies. Now, to understand a grasp action in the upper limb especially, so we need to understand human volition. So here's where, if you start reading, you need to look at the generativity, the subjectivity, and the teleology of how a particular task is being performed before we can understand in managing this. So it's just not having one group of muscles reducing the tone, but overall objective for producing volition. I think that's important. And again, to understand that what happens in stroke spasticity is there's the concept of spontaneous recovery, which is von Monacau's diastasis reversal, which is the axonal shock from the immediate effect of the injury, be it a hemorrhage or is it a thrombus, and the reversal of that, which is what we call the restoration of function. Then there is the cortical reorganization, which is both can be chemical in nature and structural in nature, and then the plasticity, the neuroplasticity that comes out. So I think this is an important thing to remember. And the other thing that you must also understand, what does spasticity produce centrally to the patient? So what happens to the patient is he has requires more energy, more cognitive load, both intrinsic, extrinsic, and germane cognitive load to rehabilitate himself. So the reduction of the spasticity reduces the load. And so the energy required is reduced. So that's an area which nobody's measuring in the outcomes. Secondly, that you will find that back to Pavlovian concept of conditioning, if I don't get the reward of grasping an object because it's too difficult, the patient has no motivation to continue the rehabilitation. So they will then look for alternative and use the opposite limb. So this is an important concept to understand. The other thing about neuroplasticity that you must understand is the concept of Hebbian learning, that repeated attempts at, and persistent stimulation of the synapses results in structural changes with the production of new dendrites and synapses, making learning occurring in the rehabilitation phase. So this is again important concept to remember. Goran Lundberg talked about, especially in lower motor neuron, this is just diagrammatic explanation of how spasticity occurred with the increase in dendrites, is the black hole that is created when you have a paralysis as a result of a stroke, which is then encroached upon by the homunculus of the other areas nearby. And this is seen in sensory parts in lower motor neuron, and I think there's a role to play in upper motor neuron. So we got this whole evidence that we read from all the literature, outside that of stroke literature and outside that of hand surgery. And we found that there is an evidence to try and bring about surgery incorporating it into the pathway. I want to make it very clear that surgery is not the end all. We play a very small part, but I think we need to choose those patients to be able to provide some form of improvement in the patient's overall experience following stroke spasticity. So this is our pathway that we have. So we work very closely with our stroke physicians, who then refer to the stroke hand clinic, which is manned by our rehabilitation colleagues, stroke physician, and the hand surgeon with an advanced care practitioner in stroke nursing. And those who are general spasticity are managed by the rehab physicians and the stroke physicians. We look at regional and focal spasticity, and we decide between contracture and spasticity. So if there's contracture, then these are standard procedures that's already been available. These are what I call neglected spasticity. And then we look at those that have got, whether they have volitional control. Obviously, if there's no volitional control, then there's very little that we can do from surgical intervention. We will continue with the rehabilitation. But if there's no volitional control, if there is volitional control, then we will do a trial of Botox injection to see whether they have improvement. And we ask the patient whether that really made a difference in his life, and would he like to have that a little bit more permanent than just the temporary effects of Botox. And if they kind of feel that, then we consider selective neurotomy. So here we have the various non-surgical and surgical. I won't spend too much. So this is these are our aims. We're trying to improve function, reduce pain, improve posture and care, and also self-esteem. And I think that's important. So we look at both upper limb and lower limb from spasticity. We not only look at those with stroke, we also manage those with brain and spinal cord injuries, and some with focal dystonia from psychiatric medication. And inclusion criteria, these are very standard inclusion. So those that have volition, that have a good prognosis for recovery, and who are willing to undergo our prolonged period of rehabilitation and being involved in the care. The exclusion criteria, any bedbound patients who are unable to communicate, we really can't. We sometimes will do certain procedures for hand hygiene. So this is our experience. We've had about 22 patients, 17 of which were stroke. Like I said, we have a couple of cerebral palsy, which is a different cohort altogether. We do have focal dystonia from psychiatric medication, which can be quite serious. So we've done a couple with some pretty impressive results. And so these are the types of nerves that we have done, selective, hyper-selective neurectomies. So here's an example of somebody with had a lot of biceps spasticity, yet pretty good volition. But every time she tries here with the gravity effect helping her with the flexion, she's good. But post neurectomy, you can see the scar in the biceps. She has a better control and a fuller range of movement, for which she is quite pleased in terms of the results. Here, I'll just show you flexor carpi ulnaris neurectomy, how they perform. So all these are done. These are very small procedures. They're not very long, done usually under regional anesthesia. We find the branch of the nerve to the flexor carpi ulnaris. We stimulate it on the table until we get contractions. We confirm that that is the branch that's going to that muscle, which already determined pre-op. And then we just excise at least a 1 centimeter segment of the nerve so as to prevent axonal regeneration and reinnervation. So this reduces the motor input into the flexor carpi ulnaris. There's usually another branch a bit more distally. So we don't remove all, we take up about 80% of the axons to the muscle. Here a couple of more examples. So this is the flexor carpi radialis neurectomy. And here we stimulate the nerve with a stimulator. So we dissect, we find the branches, and it's a highly selective neurectomy. If there's only a single branch, if you find there's only a single branch to that muscle, then we do a partial neurectomy. We cut out a segment, but leaving a fascicle intact, at least 20%, to provide some action there. So here's just a diagrammatic. This is for flexor digitorum sublimis. And here again, this is the flexor pollicis longus. So you can see the stimulation in the flexor pollicis longus. FPL may have only a single branch, then we will only do a 80%. And I think this is the improvement in the spasticity immediately post-op. Here's the lower limb. This patient had obviously the classical features of spasticity in the lower limb, with the flexor digitorum longus and the flexor hallucis longus was in spasm, as you can see very clearly in the static image. So here we provide the stimulation and do a neurectomy in both the FHL and the FDL. And you see in the post-op that he has got a better gait. And if you try and measure this, you will find that there's not very much improvement. A Fergal-Mayer score may not be great. But if you ask the patient's really, really pleased, because now they can walk barefoot in the house. They feel better, more comfortable. They are less pain because the spasticity is gone. And you can see here, the FHL is reduced flexion at the IPJ, and the FDLs are less flex. So generally, these are early results. We're still following post-COVID. We didn't run this specialized clinic, so we hope next month we're starting it again, and we'll add to it. These are, like I said, it's early days. We've been quite pleased with the improvement in the spasticity scores post-op. In terms of patient satisfaction, we have a mixed bag. We had a couple of patients who had some not so good experience post-op because of the anesthesia complication. And so, but you look at one of the patients who did better in the lower limb than in the upper limb. So he had a lot of high expectations. These are very patients who have got quite a bit of expectations. They need to be managed adequately. So the take-home message is the management strategies are evolving. I think looking at it, I think the assessment instruments needs to be modified. We're using instruments that are quite aged. They are very biophysical in nature. Nobody's measuring patient-reported experience measures, and I think that is important, and incorporating cognitive load into the instruments of measurement. There need to be more interactions among the MDT involved, the multidisciplinary team involved in stroke management. Get your hand surgeons involved. We need to counsel not just patients, we need to counsel the family, we need to counsel our colleagues in the MDT. That's what I feel. And educating and raising awareness. And I recently presented this early January in Erasmus Medical Center, and they are now very keen to start a stroke hand clinic in Erasmus. And I think this is something. What's the future? I think we need to develop and design new instruments incorporating cognitive load. So any of your therapists out there or psychologists, let's start looking at something more. Let's start measuring psychosocial impacts in stroke spasticity. And I think there's going to be a big area of improvement in the management with contralateral C7 transfers. Thank you.
Thank you very much. I had feedback from some users that they couldn't properly see your slides. I don't know what the technical issue there was, but for everyone, the session is being recorded and will be available on the WSO homepage. So you can always rewatch the session there. And now I would like to hand over to Julie Bernhardt, who's going to moderate the Q&A session.
Yay, thank you. Welcome everybody, and thank you for all of the hundreds of participants who have been present. I need to let you know that Dr. Faux needs to leave shortly, so I'm going to address the first questions that have come through to Dr. Faux. So one of the questions that's come through is around the control group and whether we know what they did as well. So we know what the intervention group did, but also, probably more importantly, you talked about choosing patients, and I'm probably going to address this to a number of you actually. And that maybe this target group was not necessarily the right target group for the intervention. So can you comment on both that small piece around the trial, but also about the choice of patients, and what do you think are good ways for us to choose patients?
Yes, thanks, Julie. There was no really good information about what patients did with the handout. We expected that they did what we asked them to do, but we did not record whether they did or not. With respect to the patient group, in my opinion, this study is very important because what it indicates is that we perhaps should be using botulinum toxin earlier in the trajectory of stroke, not very late, when perhaps contractures set in and the chances of recovery and neuroplasticity are less prominent. I think it was very good to identify that, that people at a very late stage with very significant weakness are perhaps not the right target group. And so, like many of the research that we're doing now in stroke, what we are identifying is really which are the groups of responders, who are responders and who are not responders. And I think what we're identifying is that chronic strokes, no matter how motivated they are to undertake therapy, may not be the right people to use in a study, or it might be too late to use that group, and we should be using people closer to the time when they've had their incident stroke.
Yep. Thank you, Stephen. There's a comment from Tamina Levy, who was one of the therapists who was part of the trial, saying that there is some ongoing qualitative work that will be reported as part of the study, and that there were people who were very motivated, even with very little movement, to do therapy. A lot to do with hope and belief in the process that they had consented to. They just kept hoping that they would get better. So thank you, Tamina. Now, conscious of time, I'm going to turn my attention and I'll go back to actually our first speaker. So I'd like to ask you, Dr. Latif, there are a few questions here about the time course of taking your approach, slowly working through the interventions that you talked about as part of your management for your case. And particularly, I'd like you to also, I think, re-emphasise the importance, or talk to the importance of the strengthening training in addition to the other types of things you applied. So okay, the questions specifically, if I want to get you down to, is when do you apply them? How long did you need to use it for to start seeing some of these changes?
Okay, so when we identify the patient has spasticity, and we recognize that it does interfere with any of the function, so we then would start looking at how to improve on the patient's goal. So for example, in the video that I showed just now, the patient is a walking patient. So the spasticity does interfere with his walking. So as soon as we recognize that there is spasticity and it is interfering with function, then we will look into the management of the spasticity. For this particular case, we prescribe him with muscle strengthening, because we know that muscle strengthening do not, it's very important, because even though we know that the spastic muscle is a strong muscle, but the antagonist muscle usually is a weaker muscle. So even before we, for example, want to consider a botulinum toxin injection, it is very important to ensure that the patient goes through a strengthening program first. So we do facilitate the strengthening program. We prescribe the orthosis, and we do encourage patient to come for therapy and do the stretching and teach him a home therapy program for this patient. Yeah, the second question is?
I think one of the questions is, how long did you use the orthoses for? And in your experience, you know, how long might someone need an orthosis?
Okay, so usually the orthosis will be used for quite a long time, but sometimes as long as it is interfering with the function, and if they are not their compliance with it, they keep it. But some patient, you know, there is issue of compliance. So for us, as long as there is spasticity and it is disturbing the function, they are to use the prescribed orthosis.
Thank you. And as I expected, there was a question from Michael Tunguya. I'm sorry if I mispronounced that, Michael, from Africa, saying that they don't have botulinum toxin and very few surgeons. So what rehabilitation programs, there's a rehabilitation like self-rehabilitation contracts, which I'm not familiar with, Michael, but the types of things that you've been discussing, can they help with improving spasticity and recovery if you don't have Botox or surgery?
Yes, we have to understand that in dealing with spasticity, Botox is not always the first choice. You still need to do the basic rehabilitation, which include the muscle stretching, the muscle strengthening, positioning. So if you can, if you get the spasticity early on, that means the MAS score is still 1+ to 2. They should be able to manage the spasticity with rehabilitation. But of course, you know, this will definitely will prevent the complication. Yeah, so that should not be an issue for low resources country like botulinum toxin is not available and surgery is definitely out of the question. So they should be able to adopt a low sort of like basic rehabilitation to try to reduce. Yeah, management plan.
Perfect. Thank you very much. I'm going to turn and ask you a few questions now, Dr. Rajaratnam. I'm very interested in the surgery discussion. I think there are a couple of points I'd like to you to elaborate on, if you wouldn't mind. One is around your point of trying to select patients. So I'm going to come back to the selection piece around good prognosis. Is there anything in particular, given we're not clear about how people might progress after their stroke, what do you use to determine good prognosis? Do you use markers of integrity of corticospinal tract or anything like that? So that's the first question I'm going to ask you.
Yeah, so I think for me is the role of the Botox is to see whether it's a therapeutic trial. So we'll give them the Botox, or they have that done from another physician. They come to us and they say, look, I was great for Botox 3 months and then everything came back. So we use a qualitative method because that's what I think the patient's experience is important. How did you find it? Was it worth a while? He said, yeah, it was great. So if they thought it was worth a while, then the surgery is a little bit more precise because Botox is just injecting into the belly. So we choose the nerves and then we do it. One of the things that we have found, again, qualitatively, is that just doing a reduction in the gamma reflex feedback, because that will go when you do a neurectomy, you find that other areas improve. And so people think that, oh, this is crazy, you know, there's got nothing to do with it. No, because you must understand what happens there is a homunculus in the brain stem. There's a similar homunculus in the brainstem, and there is an over-discharge occurring there. Just by reducing the gamma reflex, I then reduce the spasticity in other areas where the motor neurons are similar. So it's very qualitative. We ask the patient. Yeah.
So it's more, so really when you're talking about prognosis, you're talking about whether they've been a responder to Botox prior to you selecting. Okay, thank you. And then my other question, because you know this is significant surgery. It's small, I know, but it's still you know, opening people up. Can you tell us about adverse events? And then if you have any, is there sensory problems? And also, whether you think now that you've done this early preliminary work and you're starting to see these signals that may show benefit, do you think you'll take this into trials into the future?
Yeah. So yes, I think that's where we're going to head forward. So in terms of the RCT that was done in Shanghai, they did that with the C7 route. We have no sensory problem because we're cutting the motor fibers. So this is spasticity, so we identify the motor, there's no sensory. Coming back to low and medium income group countries, we, because we go to Cambodia, so we train the Cambodian surgeons, so they do neurectomy there because they have not so much stroke patients, but head injury patients with spasticity. And they got no Botox, it's too expensive. So there we don't give the Botox, but we just speak to the patient, a lot of counseling, education, and we do it. So the only thing I would add is we can't really predict exactly what's going to happen because of the central effects of the reduction in the gamma reflex.
Mm-hmm. But there might be other adverse events that are associated with the surgery just because of surgery, correct?
Yeah, so
right.
I must, so that's one patient, and that was purely an anesthetic problem. So where the anesthetist lost the airway.
Mm-hmm.
And so, you know, so he had a bad experience, but, you know, we had to abandon surgery halfway and then come back the next week and complete the surgery. But they are all, because though they are post-stroke patients, the anesthetists do a proper evaluation, and quite a few have done under regional anesthesia. So the patient's awake, and
yes,
so we're,
right. Well, I think it'll be very interesting to see how that progresses, and also how you progress this into a trial environment. There are been some very interesting questions that we haven't been able to get to, but we have them recorded. So we may pass them back to you to have some additional questions answered, but I'm conscious that we've come to the end of our time. And so thank you. I just want to thank you, and I'll hand back over to Alina, but that was a very interesting session. Thank you very much.
Yes, thank you all for participating and for this very lively discussion. I know there are loads of questions that have come in, but as Julie said, we'll record them and try and maybe post them on the WSO homepage together with some answers. So, and also we encourage you can also go on Twitter and have a chat about these conversations and keep the conversations going. So
that's true.
Yeah. Thank you everyone for joining, and have a lovely evening, good afternoon, and see you soon.
And thank you very much again, speakers. Thank you.
Bye.